So, good morning and good afternoon, everyone. My name is Duncan Selbie, and I'm the president of IANPHI. It's my pleasure to moderate this webinar this afternoon and to spend some time together about the risks of heat on health, and in particular how those risks may have changed in recent years and during the pandemic, and what lessons there might be for post-pandemic planning, as heat will remain a big risk and taker of life. We have two parts to this today. We have contributions from three speakers from national institutes in different parts of the world. And then we have a panel of distinguished experts and senior representatives from national institutes, with plenty of time afterwards for Q&A with the panel members, but also the contributing speakers. And so without further ado, I want to introduce the first of our speakers, from Public Health England, Owen Landeg. And Owen will speak for about 10 minutes, and then we'll pass over to his colleague Werner Hagens from the Netherlands, and then Shubhayu Saha from the US. Owen, are you ready to begin?
Yes, thank you, Duncan. Good afternoon. Hello, everybody. My name's Owen Landeg. I am the scientific and technical lead in the Extreme Events and Health Protection team at PHE. We are the operational leads for the Heatwave plan and the underlying heat health alerting system that we have here in England. So I just want to start really with a reflection on the meteorological conditions of summer 2020 before moving into what we know about the health impacts of hot weather and what was observed during summer 2020. I'd then like to raise awareness of the Heatwave plan for England itself and some of the updates that we've made for 2021 before then introducing a new heat warning system that will be active this year for this summer in England. So when we look at summer 2020 from a meteorological perspective, it was pretty much a mixed weather pattern overall. And when we compared it to the last 30 years, it was slightly warmer than average, but we certainly had distinct periods of cooler periods and also wet conditions in England. We did, however, have three distinct episodes of hot weather and heat. The first was in late June. The second was in late July, when we recorded our third highest max daytime temperature of 37.8 degrees Celsius. And then we had a particularly prolonged event on between the 5th and the 15th of August, which included 6 days above 34 degrees Celsius. And in the night, we didn't see temperatures drop. So we had tropical nights where temperatures remained above 20 degrees Celsius. In terms of the health impacts of hot weather, well, exposure to indoor and exterior high temperatures really causes a range of heat-related illnesses. And the main causes of illness and death during the heat wave are cardiovascular and respiratory. And these aren't often recognized as heat impacts. And that's why very often heat is described as a silent killer. There are specific heat-related illnesses. These include common symptoms such as heat exhaustion, which are, from time to time, we've all suffered from, maybe on a temporary measure. And the importance really of these heat exhaustion symptoms is to recognize that they are indicators that our bodies are working harder. And it's that strain that's been put on the heart and the lungs, coupled with fluid loss, that can lead then to the progression to more serious health outcomes, such as heat stroke, which is a medical emergency. When we look at the evidence and the observations around 2020, if we look at the PHE syndromic surveillance and the indicators that we have for heat stroke and exhaustion, both in daily emergency department attendances, but also daily ambulance call-out. What these graphs show is that during the periods of heat in England, we did see observed heat health impacts and indeed a presentation to the health system. However, we should recognize that we need to interpret these with caution, as the COVID-19 pandemic has had significant impacts on our surveillance systems and makes interpretation more tricky. Secondly, we also need to recognize the absolute figures here, and they're relatively small, particularly in comparison to the overall presentations that have been made to the health system. And for that reason, 2020 was in line with other episodes where we don't see typically this big surge in presentations to the health sector, but we do see an increase in deaths. Moving to the deaths, over the course of the 3 periods of heat that I've described in June, July, and August, these are represented by the grey bars here on the time series. And across England, what we saw over the course of the summer in 2020 was all-cause excess mortality of 2,556 people. This is the highest excess all-cause mortality that's been recorded since we introduced the Heatwave plan in 2004. What the time series does show is the very quick and rapid increase in deaths that occur once temperatures start to rise. And what this means from a public health perspective is that the window of opportunity to take preventative action is typically very short, and that stresses the importance then of pre-summer preparedness and long-term strategic prevention work. During each episode of heat in summer 2020, a corresponding peak can be observed in all-cause mortality, particularly among the 65 years group. And you can see that quite readily on the time series itself. If we break that down slightly more, we saw excess mortality across the majority of regions in England, apart from the far north of England itself. But if we break down the mortality by age, you can see that each period of heat, so June the 23rd to the 27th, July the 30th to the August the 1st, and August the 5th to the 15th, had statistically significant excess mortality associated with it. The majority of the excess mortality occurred in August the 5th to the 15th, the 3rd period of heat, which was particularly prolonged, but also we didn't have this respite in the heat during the evenings and overnight, with these tropical nights being described by our meteorologists. So we see this significant excess mortality across all these periods, and the greatest excess mortality was observed in the 3rd period. Something we haven't seen before at a national level is an excess mortality at 45 to 64-year-olds, and this was observed during that 3rd period of heat I've described. So when we started looking, and the team started looking at the epidemiologically, at the epi around the excess mortality, we looked then at the location and what the causes of these deaths were. And what we saw was a significant excess mortality was observed in homes, so domestic homes, but also within care settings. And this was across all 3 episodes of heat, particularly for the over 65-year-olds group. Also in the over 65 group, we saw a significant excess mortality within hospitals during the 1st period in June and the 3rd period in August. Deaths at home and in hospitals also increased significantly in the under 65 years group during episode 3, when we compare that to non-heatwave days in 2020. But of course, an impact of COVID-19, the COVID-19 pandemic, has been a general shifting of patterns of where deaths have occurred, with more deaths occurring at home when compared to previous years for a whole host of different causes. When we look at the causes of the deaths, we'll see that the underlying cause of death categories in 2020 were circulatory, were respiratory, and Alzheimer's and dementias. And these all observed significant excess mortality across the 3 heat periods in the 65 years group. Turning to the Heatwave plan itself, as I said, the Heatwave plan was introduced in 2004 and is regularly updated year on year as new evidence becomes available. However, in recent years, the existing version of the Heatwave plan remains extant, and this is to allow the team and our partners to work on a new plan that's come in, bringing together heat and cold and other climate risks, and certainly looking more to the future and what certain projections mean in terms of the public health impacts. But that said, we do update our guidance and advice for the public and also for professionals. So I'd like to draw your attention to the new Beat the Heat guidance that we've developed. Mostly the Beat the Heat Coping with Heat and COVID-19 is primarily focused on the domestic setting and the public, but we also have keep residents safe and well. That's mostly for those in care settings and contains a poster and a checklist to avoid overheating in care settings. We've also updated our hot weather and COVID-19 slide set, which is primarily focused on professionals. We've updated our social media assets and also our communications tool, which we share with national, regional, and local partners. And then 29th of April, we actually held a stakeholder webinar with just shy of 800 people that really aim to raise awareness of the summer and the consequences of heat, but also the steps that multiple actors across the whole health system can take to prevent this preventable harm. The Heatwave plan itself is has an underlying heat health alert. This remains unchanged this year. The decision to issue an alert is made by Public Health England, having undertaken a dynamic risk assessment with colleagues in the Met Office. The heat health alerts are coordinated, and action from the heat health alerts or the issuing of a heat health alert is coordinated by the Cabinet Office here in the UK. And our heat health alerts are really there to alert people to the prospect of forthcoming hot weather and to really cite professionals and the public on the action cards and the actions people can take to remain safe and well. This year, we are introducing a new warning service. This is the National Severe Weather Warning Service that already exists and is operated by the Met Office. Now, in previous years, they haven't included extreme heat, but this is the warning service that we use for cold and other types of extreme weather. We've designed the new Severe Weather Warning Service for extreme heat for events such as those in last August, so those particularly severe or particularly prolonged heat events. So it's particularly tailored this year for that audience. It focuses on impacts, not just in the health system, but across the whole sector. So it includes transport impacts, for example, or impacts on power generation that occur because of heat. And it's generally focused upon the general population, whereas our own heat health alert service is mostly focused on the health and social care system. This year, we will be running the new warning service. It became operational in June, but it's important, however, we remain closely coordinated between the two warning systems this year. That means that we avoid any confusion at the front line, and we make sure that if we do see a significant or prolonged heat event within the forecast, that we can really amplify the public health messages this year and increase our reach to our vital audience. So in conclusion, the key findings from 2020 are that we saw the highest mortality since the introduction of the Heatwave plan in 2004. Summer 2020 temperatures were not record-breaking. They weren't the hottest that we've seen in England. However, we did see these tropical nights during the August events that probably played a part in causing the excess mortality. And of course, then the interaction with the countermeasures associated with COVID-19 also possibly amplified these impacts. 68% of our total heatwave excess mortality occurred during this third episode. But what we hope is through doing the work that the whole team has been undertaking with other teams in NPHI, is that by identifying the place and cause of death, that we can permit more targeted public intervention, particularly for the vulnerable groups, but especially for those who are unable to adapt their own behaviours or indeed their own environments. So with that, I'd just like to acknowledge the whole team, the whole of the Extreme Events team and the work that they've all been doing on this, but also then the wider EPI and data teams that have really been helpful in bringing this work all together. And I'd like to hand back to Duncan.
Owen, thank you so much. That's incredibly rich, lots of resources. Also making the final point about the most vulnerable, again affected mostly by this particular risk. Thank you, Owen. We'll move straight on to Werner Hagens from the Netherlands. Werner leads on the Heatwave plan for his country. Werner, are you happy to begin?
Yes, I'm trying to get my presentation on. Yes. My name is Werner Hagens. I work for the Dutch RIVM, the Dutch National Institute of Public Health and Environment, and I'm responsible for the Dutch Heatwave plan. The Dutch Heat Health Action Plan, it's called in Dutch Nationaal Hitteplan. In this plan, RIVM is in the lead. This plan is commissioned by the Ministry of Health. It's already there since 2007. The ministry asked RIVM to come up with this heat plan because of the very warm summers of 2003 and 2006. Other countries already had heat health action plans, and in the Netherlands they weren't there. But still, there was in 2003, 2006 more than 1,000 excess mortality. So the ministry wanted to do something about that. Since 2007, this plan is activated 15 times up till now. And the structure of the Heat Health Action Plan, in the next slide, I'm going to show you how our structure is. But in my opinion, a structure of a Heat Health Action Plan is based on the existing national and regional institutions which are already in a country. So it's based on what is already there. And every country has its unique heat health action plan. The WHO identified 8 core elements for successful implementation. A few of them are there should be a lead body, accurate and timely alert system, information plan, but also the particular care for the vulnerable groups. I'm going to show you now how the Heat Health Action Plan looks in the Netherlands. First of all, you have a national level and a local level. On the national level, the Dutch Met Office gives information to RIVM timely and complete, also good in advance, hopefully always. And then RIVM gives this information to our our heat partners, and the heat partners are the National Association of a lot of caregivers, general practitioners, pharmacists, also elderly groups, the Red Cross in the Netherlands, and also in the Netherlands we have the municipal health services. We also give them directly our information, and it's those people, those associations can give the information they have to their counterparts, to their stakeholders. So it's a timely information structure. Based upon after activation, RIVM gives a press release, and the media does always covers this press release, which gives information to the public. Also, if you look at COVID-19 and RIVM, we also have a lot of responsibilities for that. The RIVM advises the Dutch government on how to control the outbreak as effectively as possible. Also, RIVM monitors the COVID outbreak and conducts research into SARS-CoV-2. but the Dutch government is responsible for the communication to the public. RIVM shares up-to-date information and knowledge on COVID with the Dutch government, of course, and also has a very complete website with a lot of information on it on COVID. And everything is in one institute. So within RIVM, we have ongoing internal communication between the heat health experts, also people from infectious diseases and communication experts to ensure an alignment of all public health messages. And if you then look at COVID-19 and heat, when the outbreak of COVID-19 started, first of all, what we did a comparison with the COVID-19 guidelines as they were emerging to exist, and also compared them with the heat health guidelines. And what we saw directly was that was almost a complete overlap for the people at risk. So what we should, what we try to do then is ensure no contradiction of the public health messages. Around the same time when we compared the guidelines, there was also a participation, a network from a project from the Global Heat Health Information Network. And I also participated in this project, and for me it was quite beneficial to be in this Global Heat Health Information Network information loop. Because I knew when information was finished, and I could already make a few presentations and information sheets for Dutch heat health partners. And I gave last year a few of those presentations to our partners, so they knew that what to do with COVID-19 and heat. And we also use the information for question and answers, which we put on our own RIVM's website. What is very important in heat health action plans is the communication. And in 2020, we started with making new communication materials. We made the infographics and also short animations. At the side, you see how our infographic looks like. It's in Dutch, but I think it's quite general on the measures, the public health messages. What's in there? Drink enough, keep yourself cool, keep your house cool, and take care of each other. And also a particular medicine and heat and what to do with it. But by making new communication materials, we could also ensure that they were in line with the COVID measures. So, for instance, for example, take care of each other. It now says give a call and ask what you can do. So then you can ensure also the 1.5 meters distance. But what we also were doing was that the photos we used, we had to make new photos, because in the photos we normally use, people were sitting too close to each other, so we couldn't use it. So that also means a lot of new materials were needed. A few pros and cons on the communication of last year. Well, the COVID-19 and heat health messages from the same public health institute. Well, we could align all public health messages, and next to heat, we also have messages about ultraviolet radiation, but also ozone and summer smog during heat waves. So that was good to have it aligned, but also if you have several public health messages from one institute at the same time, you have your public health messages for COVID-19, which were all in place the whole time. You have the heat, you have the UV, you have the ozone. So that's a lot of messages, and how many messages can you send from one institute? And also another thing, RIVM was already in the news daily for a long period, and that's the trust in public health institutes, which might become an issue after such a long COVID-19 outbreak. Another thing is that in the Netherlands, we have a lot of heat partners, and they also started communication on heat and health. And the media coverage of last year, 2020, we saw that the media covered a lot of the heat partners instead of the RIVM. And I think that is that's a very good thing, that we also see that awareness on heat and health is increasing, and it's not only RIVM giving all the information, but other partners are giving the same information, and we are the architect of the plan. We are saying when it is needed to give the warning systems, the warnings, but a lot of people, a lot of parties join in. After every year, we do an evaluation of our heat health action plan amongst our heat partners, and the heat partners are in the national level, the national associations, the Red Cross, the municipal health services. And last year, we had a 2 times activation of our heat health action plan. And the second time, what Owen already told, was a very long period for almost 2 weeks. And in the Netherlands, the excess mortality of that period was 650 people in total, which was less than the 2003 and 2006 years, but still 650 people is a lot. If we then look at the evaluation, the heat partners were satisfied with the timely and complete information they got from RIVM. Also, the heat partners send out public health messages to their stakeholders and to their local heat partners. So it's a very good system which gives the information on the places where it needs to be. And also the heat partners appreciate it and used the new communication materials, and also used the COVID-19 and health and heat question and answers. And for 2021, we don't know what's going to happen, but we already started our messages to our heat partners and asked them to be prepared for this year. Thank you.
Werner, thank you so much. And some of those images are striking. Thank you. That's very instructive. Thank you. I'm going to move us on to Shubhayu Saha from the Centre for Environmental Health at the US CDC. Shubhayu, are you ready?
I am.
Over to you.
Can you see my screen well?
Yes, we can. Yes.
Thank you so much. Greetings, everyone. Thank you so much for the invitation to share and learn from you all. My name is Shubhayu Saha. I am a health scientist with the Climate and Health Program at CDC. And in this very short presentation, I would do 3 things. I would briefly describe the Climate and Health Program, present 3 broad areas around data and analytics that we routinely work on as far as health, heat and health impacts are concerned, and share some of the agency's extreme heat preparedness efforts during the pandemic. So CDC's Climate and Health Program, it's the national leader in empowering communities to protect human health from a changing climate. We just celebrated our 10th anniversary last year. Broadly, the program serves as a resource on climate and health for federal, state, local territories and tribal health agencies across the country. We build capacity among public health practitioners at local health agencies to address the health effects of climate change. We provide tools, guides, and processes to help assess vulnerability and equity concerns around the possible health impacts with climate change. And across the federal system, we lead the planning and implementation of public health adaptation strategies associated with climate change. So an important part of our work around extreme heat deals with assessing the risks from heat exposure. And so I will briefly mention 3 projects related to data, analytics, and tools in this domain. So for data, I will mention how we have disseminated location-specific exposure information through an online data portal. I'll provide an example of our analytical work assessing health risks with heat and how that information is being used in implementation of heat warnings. And lastly, I would talk about an online tool which is being developed to provide near real-time information on heat-related illness and temperature. So as we started working with partners in local health departments, the climate and health program, we saw that there was an unmet demand for local weather or climate information, particularly on extreme heat. The data that was publicly available were often in difficult formats to work with and in spatial scales which were not appropriate for health decision making. So we worked with colleagues across federal agencies, primarily NOAA, to transform the temperature data at the county scale and make it available through the CDC's Environmental Public Health Tracking Portal. This is the tracking, a snapshot of the tracking portal that you see. And so as a user, one can select the specific county, which in many parts of the world would be districts, and year, and also customize the heat, the criteria used to define extreme heat. So for example, one could use daily maximum temperature or daily heat index, an absolute or a percentile-based approach to define anomalously high temperature. And these are the kinds of outputs that you get. So for a specific county, for a specific year, this shows the distribution of daily maximum temperature. All of this information can be downloaded for free. And when we first provided this information to stakeholders across public health agencies, we thought that this would serve an analytic purpose where practitioners would link the exposure information with the health information to do analytical work. But much to our pleasant surprise, we see that a tool like this is increasingly used for communicating why extreme heat is a public health concern locally. In a project led by my colleague, Dr. Ambarish Vaidyanathan, we examined the heat index range at which we observe an increase in the burden of a range of adverse health outcomes requiring hospital admissions. This was a paper that was published at the Proceedings of the National Academy of Sciences. This particular graphic that you see on the left, we essentially grouped different states for which we had hospital admission information. We grouped them by different climate regions across the country. The horizontal yellow to red gradient shows the sensitive heat index range for each of these different outcomes that we investigated. The red and white checkered box in the middle indicate the temperature range at which the largest burden was observed that was attributable to the heat index. You can see that how this most sensitive heat index range varies across different regions of the country, which basically requires customizing these heat alert criteria depending on the specific part of the country where you are. We also plotted the heat index range at which heat alerts were conventionally issued across these jurisdictions. And so for most part of the country, we essentially saw that the alerts were being issued at heat index ranges, which were different from where the largest health burden was observed, that checkered box that you see in the middle. This led us to convening an interagency expert meeting that contributed to a possible recalibration of the approach in issuing heat alerts. The graphic that you see on the right, it's an experimental product from the National Weather Service called Heat Risk. And this product is using the results from this epidemiologic assessment that I mentioned, so that the system can move away from a binary way of issuing heat warnings, to providing health information, heat risk information along a continuum of risk. Extreme heat events have increased in frequency, intensity, and duration across the country because of climate change. However, there is currently a paucity of near real-time health information that can provide situational awareness to decision makers during heat waves. So using this online tool that is being developed at CDC, we are trying to disseminate near real-time health information overlaid on ambient temperature data to inform heat preparedness efforts across public health agencies. The health information on heat-related emergency department visits essentially come from the National Syndromic Surveillance Program at the Centers for Disease Control and Prevention. So because of data confidentiality protocols, we are only, as of now, able to display this health information at a regional level as defined by the Department of Health and Human Services. The underlying temperature data is obtained from the National Oceanic and Atmospheric Administration, and the color gradient shows the weekly average of the daily maximum air temperature recorded in each of these specific counties. We do recognize that ambient temperature is only one of the many factors that contribute to heat-related illness, and the overlay of the temperature and the heat-related illness does not imply causation. But the fact that this information is now available and we are in a position to share this with public health partners really expands the opportunity as to how decision makers can adjust heat response strategies as and when required. Access to cooling shelters has been an important public health intervention to prevent adverse health outcomes in communities particularly vulnerable to extreme heat. There is strong evidence that staying in a cool environment can help maintain a safe core body temperature and reduce mortality and morbidity during heat waves. However, specifically in the light of the pandemic, the use of the cooling centers, raised concerns around congregation of groups of at-risk people, particularly older adults or those with respiratory disease, and potentially provide a route for the transmission of the SARS-CoV-2 virus and subsequent development of COVID-19 symptoms, not only among the visitors, but as well as the staff working in these shelters. So in this context, revised guidance was issued by CDC on how to plan and operate cooling shelters when needed. So for example, based on availability of resources, operators were advised to consider implementing verbal screening or temperature checks before admitting visitors to the cooling centers. When possible, it was recommended to provide alternative cooling sites for those showing symptoms of COVID-19. There was guidance on physical distancing at the shelters, air filtration systems that were used within the facility, as well as cleaning and disinfection protocols, to be followed at the facility. Since individuals was going to spend large amounts of time indoors, there was also a recommendation to consider implementing or expanding programs that provide home energy assistance to low-income families. There was a recommendation on a temporary ban on utility shutoffs during heat waves that would allow people to continue using home air conditioning, a strategy that we thought would lower the number of people utilizing or going to a cooling shelter when required. I thought it's worth mentioning, to make things worse, a heat wave hit the western part of the United States as the wildfires were raging in September last year. So these compound hazards exacerbated concerns around operating disaster shelters that individuals needed for respite from exposure to wildfire smoke, as well as oppressing heat. Specific guidance was issued on ways that individuals and families could prepare to access these disaster shelters, how they could protect each other while at the shelter, with specific guidance for children, pets, people with pre-existing conditions, and emergency workers. An interesting issue for us was to examine what happened to heat-related illness during the pandemic. You've already heard about a few other studies from England and Netherlands about it. We had recently access to heat-related illness data from the syndromic surveillance system, as I mentioned, which allowed us to make broad comparisons across 2018, 2019, and 2020. So the graphic on the left shows temperature data in green and rates of heat-related emergency visits in blue by weeks, as defined by the Health and Human Services region. This was specific to Region 2, which covers New York and New Jersey, the states of New York and New Jersey. As you can see, while the weekly distribution of the temperature metric was similar across the 3 years, we observed a relatively lower rate of heat-related ED visits in 2020 compared to the previous years in this particular region. Compare that with the data that we had for Region 9, which comprises California, the states of California, Arizona, and Nevada. Again, the weekly distribution of the temperature in blue was similar across the 3 study period, the 3 years. But the rate of heat illness emergency visits was higher in 2020 compared to what we saw in previous years. We see that there's some discrepancy, differential patterns that we see in heat-related illness in the pandemic years, and we plan to use more granular health and temperature data to assess how patterns of these heat-related illness patterns may have been, different across different parts of the country. You already heard about the Global Heat Health Information Network being mentioned. This particular resource was curated by Jin. You will probably hear more about Jin during the panel discussions. Along with a host of international experts, various units within CDC provided valuable information on effectively managing risk from extreme heat across vulnerable groups, with a specific emphasis on occupational safety. On the website, there's a technical brief and a checklist that's available, which describes key consideration for decision makers and practitioners on adapting existing plans, protocols, and procedures for managing the risks of extreme heat during the COVID-19 pandemic. So in conclusion, cooling shelters will continue to be an important strategy to prevent heat-related adverse health outcomes in the summer of 2021, of course, with adequate precautions for safety of those visiting as well as those working at these facilities. We really look forward to expanding the use of real-time health information, particularly that comes from the syndromic surveillance apparatus, to inform local public health action. This real-time information on heat and health and environmental surveillance will soon be available on a CDC portal. It's called the CDC Heat and Health Tracker. Thank you so much, and I look forward to discussions and questions.
Shubhayu, thank you so much. I mean, the contributions from you and colleagues have been excellent. If in the very minimum, in raising awareness of the assets and just how consistent the messages are around the world. Today is about raising awareness of the health risks of heat. I mean, most people perhaps think of heat as a good thing, but I think we're looking at a tripling of mortality by 2050 by climate change, and we've just got to pay more attention to this and to take the opportunity to learn from each other, which is what the next session is about. And before I introduce our panelists, I think we may have put on the chat box that what we're looking for are people to raise questions. We'll try and theme them. I've got one or two to get us started, but we'll look to people posting their questions, including to Shubhayu, Owen, and Werner. So we have 4 panelists. We have 2 who are expert in heat-related risks, and we've got 2 very senior colleagues from national institutes. So I'm going to introduce our colleagues now. We have Céline Campagna from Quebec. Céline is on the climate change and health team. We have Juli Trtanj from the National Oceanic and Atmospheric Administration in the US. Geneviève Chêne, who's the Director General of Santé, publique France, Public Health France. And we have Ramiz Khan from the Red Cross, the Red Crescent Climate Centre. Can I just check, do we have all of our panelists? We have all of our panelists visually and off mute. And let me just check the chat box. If we begin with a question, and if I address this question to perhaps Juli and Geneviève in the first instance, how to build a comprehensive prevention plan for both heat health risks and COVID-19. So how do we build this into a comprehensive prevention plan, and then reflecting in our recovery plans from the pandemic? Some thoughts. Juli, would you like to begin?
Sure, I will actually, and I will say that I'm wearing a couple of hats in this conversation, and so I am also not only from NOAA, where I work on the climate and weather side of this equation, but also representing the Global Heat Health Information Network, which you've heard about before. And I say that because that is part of my response. I think Shubhayu and I and the folks at CDC, we've been working together for a while. I've been at this for probably over 15 years. I don't want to say more because that's incriminating myself, but been at it for a while. And if there's anything I've learned, it's the time to build those relationships is not during the emergency. The time is to have the network, to build, much like the system it sounded like the Dutch have. And Shubhayu and I worked together on this thing in the US called the National Integrated Heat Health Information System. You want to have the network across the sectors built beforehand, and build not just so that it can be stood up in a moment, but so that there's trust in a relationship that goes over time. Because when you're talking about predicting something, it's one thing to do a weather forecast. We didn't start out really good at doing weather forecasts, and we still kind of blow it sometimes, but people still trust us because we've been at the table with them for a while. And I think we're still getting to that point with the environment and health and the climate and health side of things. We aren't quite there yet. So that trust becomes really important. And the partnerships across the network of sectors and disciplines and decision makers is really important. And so I would say that is one of the primary things. And the second was just to be engaged. You know, we were really impressed from the GIN perspective that so many health departments participated in that and then used the information for their own health department. So we really helped solidify the messaging by coordinating on the very front end. And I would suggest then for ways to avoid this in the future, or to manage better in the future, to build the partnerships with your climate and weather people now, to, you know, partner with GIN and learn from each other, and think more broadly going forward, and incorporate the cost of that, the resource cost, the time cost, the technical cost into your recovery plans. Thank you for the opportunity.
Julie, thank you so much. Geneviève, would you wish to come in?
Yes, good afternoon, and thank you very much for the invitation. So and thank you very much for the presentations that were really already very comprehensive around this this topic. Just to say that in France we had also an extreme summer temperatures last year. That was the highest level of warning since the heat prevention plan that is deployed in France since 2004. So we encountered the same experience as many of our colleagues in different countries. And we estimated also, that's very important, 1,900 excess deaths during these heat waves. That was the most deadly summer since 2003. And this was really important also to analyze that these deaths were this excess death started after 45 years in those older than 45 years old. So it's also interesting because that's a target for the population to be more aware about the risk. And also we identified that that was not homogeneous across France, but in three main regions that we observed 50% of the death, and especially up north where the population has less habit behaviors or to deal with heat waves. So if I come back to your specific question, I completely agree that we need a global approach that is durable, because both events and conditions are durable, and integration, as mentioned already, and trust among the different partners is really important. With three different aspects I would like to underline. The first one is to continue to communicate indeed and increase awareness, because sometimes, and in some regions, COVID may have decreased the perception of risk of heat waves, and we need to continue to increase awareness, as sometimes the tools or the resources or the actions that we need to take may be in competition to prevent both conditions. The second aspect is to develop tools, and there has been outstanding resources that have been presented in this session for protection. These resources are available in all types of to communicate, and this is absolutely crucial, and also to have shared or a whole network of local partners, because we need to act locally, especially in regions where the behaviors to deal with heat is less implemented, or also with more vulnerable populations. And the third aspect is also to continue to develop preventive environmental measures, of course, in terms of proactive adaptation to new climate, but also reduce urban heat islands, for example, reduce air pollution, etc. So continuously also act to decrease or mitigate climate changes in climate. Thank you very much.
Duncan, you are on mute.
Thank you. I was on mute. Geneviève, just to say thank you for that. They covered a great deal of ground, and I should have said that we are recording this today, and there will be a note from today's seminar that we can distill the key messages and share them widely. Can I also offer the opportunity to Céline to comment, and then I've got some questions from the floor. Céline?
Yes, thank you for the opportunity to talk today, and it's really a great panel. I completely agree with Julie and Geneviève about like the importance of to cultivate the collaboration before the emergency, and I would add that we have to take lessons of the great coordinated and a fantastic coordination and transdisciplinary actions during COVID. If I put the heat plan apart, like the COVID integration of multi-teams, multi-partners at a very short timing was great. Like just in our institute, there was a really quick, many teams on COVID, different teams that went together from different perspectives, different expertise that worked together and to be sure that the response was quick and up to date with the science, like on real time. And I think we should take lessons from that to improve our heat plan response, because we have been working with heat partners, meteo partners, and now we have to open to like even more better coordination with other sectors, even at a upper level as a public health institute.
Céline, thank you ever so much. I'm now going to try and merge questions from the floor with our speakers and our panelists. So there's a theme coming through about mental health and how well integrated thinking about mental health is in the various heatwave plans. There's a particular question put to Werner from RIVM, but our panelists might wish to comment in a moment. Werner, do you want to just have the first reflection? Mental health.
Yeah, mental health is not a part in the Dutch heatwave plan, but if you look at mental health and COVID, RIVM has got a lot of information on that also on the website, and there is also a big program on mental health and COVID running at the moment. And actually, well, we can participate with them if needed.
Thank you. There's, of course, a whole impact of the COVID on mental health, and what we've all been paying more attention to this in recent years, but this is a very important reflection, I think. Do any of our panelists wish to comment? Ramiz, perhaps? Céline or Geneviève, Julie?
I think Ramiz just unmute.
Yeah, sorry, I lost my connection, my internet connection for some time, so I couldn't get the question. Would you please mind to repeat the question, please?
Oh, thank you, Ramiz. Well, did you hear there was Werner was reflecting to a question about the importance of mental health in our thinking about a comprehensive prevention plan and the effects of heat, and whether you had any reflections to offer on this, on mental health and the heat risks.
So of course, mental health has a huge importance. It's like from the COVID perspective and from the health perspective, heat perspective as well. There are lots of for the COVID. I know during the COVID time there are lots of online counseling process that has been that is being organized by the respective governments in various countries. That is happening for the heat also. Very honestly, heat is not a very priority subject still in many countries, especially in the global south. If you see the countries, heat is not a very priority subject. So still, it hasn't reached to that level that they will consider about the mental health and heat. They are now trying to identify the relation between the health and heat. It is in that stage where they are trying to establish the context whether heat is actually a silent killer, whether they should consider heat as a disaster or not. So it is at this stage at the moment. I'm talking from the global south perspective, especially, and it is taking so much effort to mobilize the government. Like heat is a disaster, a silent killer. That is what we are facing at the moment in many countries in South Asia and Southeast Asia. So yeah, of course, I believe the mental health has a huge heat has a huge impact on mental health, and we need to consider this as one of the remedies. But at the moment, I'm not very much aware that lots of work is happening on the mental health and the heat.
Ramiz, thank you. Yes, please, Julie.
So just Ramiz, one comment on that too. I was just on the phone earlier with some folks in the Asia Pacific region who are talking about how to raise awareness about heat as a problem. So even in the United States, our Federal Emergency Management Agency does not recognize heat as a disaster. And yet when it comes to mental health issues, in our climate assessment, we had a whole section for the first time on mental health, and heat is a big confounding factor for homeless populations, for marginalized populations, underserved populations, and for those who are on prescription medicines, which is a lot of the elderly. So there's a social isolation piece, there's a medication piece, and then there's just a social justice and equity component to it. So I think for us in the US, we're beginning to grapple with not having heat be officially recognized yet as a disaster, and yet the health community completely understanding that it is. And so, yeah, we're in the middle as well. But I think the groups like yours taking this on and raising this issue are enormously significant in helping. I mean, we're not on the health side of things, so unless you all would take the lead and say that, on the Met and climate side, it would be hard for us to do much about it. But we are seeing shifts in thinking, but not institutional shifts just yet.
Thank you, Julie. Geneviève, there's a question in the chat box about a particular approach that France takes to heat. I think if I've tracked it down, about the impact of heat on medication, and I wanted if you wanted to add anything.
Do you mean on medication or mental health, or?
Well, the medication of people with mental health problems.
All right. No, so I think that Mathilde is, and thank you very much to Mathilde, who is providing comments and response. What I can add is that just three things on mental health to complement what Mathilde posted on the chat. The first thing is that where we are in terms of our surveillance of mental health symptoms in France during the COVID crisis is that we see with different with a survey with different waves that we have every month of the population that 1/3 of the population in France experience symptoms of depression or anxiety, which is quite high, and so the response to that is also to increase the surveillance in terms of syndromic surveillance every week, especially in terms of surveillance of the youngest who experience mental health symptoms more than we thought initially, and also to launch a communication campaign to talk about signs of mental health, whatever their relation or regardless of their relation to climate change or COVID, and also direct towards resources in terms of professionals or internet or phone lines that are able to help people with mental health signs or symptoms. So it's not specific to heat waves but it's in place.
It's general. Geneviève, thank you. There's a great question, and amongst many in the chat box, about how we differentially use volunteers, neighbours, to look out for the most vulnerable. And again, Werner mentioned this in the Netherlands. Could panelists comment about the different reflections on using non-state actors in looking out for the most vulnerable? Ramiz, you've got massive experience in this area. Would you wish to comment? I'm going to wait this time. Ramiz, do we have you?
He's connected, but he's not unmuting himself, so he might not be able to hear you, Duncan.
Well, not too much. I thought it was a great question, and that a number of our speakers have reflected on, and I wondered if others of the panel might want to.
This is Shubhayu from CDC. As I mentioned, we work very closely with state health departments and the New York's and city health departments as well, and the New York City. Not exclusively, others have done that as well, but the New York City one is probably the most well documented, where they have this sort of long-running Be a Buddy program, specifically designed to take care of the elderly and the socially isolated, specifically during a heat wave, calling them or visiting them, just to make sure that they're well. If they need any resources, if they need help to go to a cooling shelter, provide them with that assistance. I wish there was a systematic assessment of how effective or cost effective these interventions are. My guess is they are extremely cost effective, and something that needs to be studied and more systematically, and consequently championed more than they probably are right now.
Thank you, Shubhayu. Céline, what would you reflect on from Quebec in Canada?
I know some public health units in Quebec and even in Canada had volunteers, but I cannot say to which extent. But in the messages that we send and that the ministry or the public health department send, there is also like take care of call your family members that are at risk and take news from them to be sure that they are safe. As Shubhayu said, like kind of not to be a buddy, but most related to family and friends taking care of each other to be sure that there's not they're not in danger from heat.
Thank you, Céline. Did we get Ramiz back? Do we have Ramiz? Well, I'm going to move on.
Hi, I'm here. I'm so sorry. I must apologize because there is a huge downpour and thunderstorm today, and there's lots of issue in the, like, I'm at the moment based in India, and the city that I'm based in, there's a huge thunderstorm and downpour just a few minutes before, and there's a huge internet issue. So I'm losing some time the connection. So please forgive me for that.
Absolutely, Ramiz. Did you completely understood? Did you hear the question?
No, can you please repeat again? Sorry.
Well, it was a reflect. If you had any reflection from, because you've got very particular expertise in this area about non-state actors, in this case, the different contributions that neighbours and the public can make to looking out for the most vulnerable. We've heard from Werner, I think Owen would also speak to this as well. Shubhayu's just commented about the importance of engaging community in looking out for people who are most vulnerable from heat, and whether you had any reflection to add to that.
Yeah, of course. So, for example, in Vietnam, we just finished a project on like anticipatory action for the heat. It's called focus-based action on heat, and this non-state actors like for example, the Red Cross Society, the Vietnam Red Cross Society, or other community-based organization, they took a leading role for the entire assessment, setting up the trigger, and like distribution of the relief materials, and and also like house visit, community visit, those kind of activities. So it has a huge impact. But the issue that are facing is that, again, the awareness among these community-based organizations and the CBOs, for them is disaster is more, they're inclined toward like a cyclone or flood or something like that. So there are lots of success stories as well. There are lots of community-based organizations. In one of the cases, we engaged the religious body, and they was a great help. They convinced people, and people listened to them, which was a great success. And I believe it impacted a lot. In some of the cases, they're not, like, for example, the Rotary, like the institution called Rotary International, or some local NGOs, for example, who works at the grassroots level. So those also provide a great support to the government program, because government doesn't have reach out at the very community level in every cases. In that cases, we realize, and from our experience, we realize that the collaboration with these non-state actors actually help the relief and the facilities that government wants to provide at the grassroots level, at the ground level. So yeah, so that is our experience.
Yeah, incredibly helpful, Ramiz. Thank you. And Owen, I think you wanted to come in as well. Owen?
Yeah, thanks, Duncan. Just picking up on some of the other reflections around voluntary and community sector. I mean, it's a very key stakeholder group for us within our Heatwave plan, and also in our engagement. So in readiness for summer 2020, we engaged a program that's overseen by the Cabinet Office here in the UK that looks at communities prepared, and that's a cross-hazards approach, but includes heat. And that was a really important conduit for us to use to go to organized volunteers groups and those within the voluntary and community sector. And the reason it is so important is because the evidence suggests people are not identifying themselves as vulnerable. They're not identifying that maybe their homes are overheating. So mobilizing those community networks of checking in safely in a COVID secure manner were really, really important. And just lastly, you know, the kind of synergies with COVID-19 and the mutual aid community networks that have been established is something, you know, which would be wonderful if we could keep that sustained higher level of engagement across communities, which would really help us kind of identify vulnerability.
Owen, thank you. I'm looking at the chat box, and there's a range of questions that are quite specific about things like mask wearing, and PPE, and I'm grateful for responses that panelists and speakers are making. There are also a range of other observations about other impacts, rising violence, particularly towards women, particularly people who experience substance misuse. And what I'm aware is these are all, if you like, facts affecting the need to think about how we can get heat and all of its impact, the risks, and into the COVID response, the recovery plan. So I want to put our panelists, invite the speakers as well afterwards. I think if we focus on this for the next few moments, you know, we know that we've got inequalities that run right across outcomes that are derived from social determinants as well as access to healthcare, many other factors. What would you as our panelists say that we could most do? What would your top 1 or 2 messages be for a COVID in a post-COVID for ensuring that the risks of heat, the heat risks, were reflected in the COVID recovery plans to address the inequities and inequalities that run right across our nations? So I'm going to ask for contributions from each of our panelists and then over to our speakers. Céline, would you wish to, could I ask you to go first?
Yes, thank you for the opportunity. First, I cannot imagine a COVID recovery plan that will not take into account a climate lens, including heat, but at large, because any action that will not diminish the global warming will increase heat waves. That's for sure. So, and I would go even more. I would like have a mandatory justice lens over that climate and COVID recovery plan. And this is, I think, as scientists we can shout, but I think if our institute, our directors, our heads are having this discourse up to the authority, this in a strong way, it will help all vulnerable population after that. I think the first thing we have to address is not to make it worse because of the COVID recovery plan that might be economic instead of health. It's a risk.
Céline, thank you. Juli, would you like to come in?
Sure, I'd be happy to. Actually, I would second and third the include climate into the recovery plans, not just for COVID, but as the leaders start to think about not just COVID, maybe other emerging diseases and sort of longer term planning, including the environmental and climate and more of a One Health approach will get us a lot farther and less surprised, you know, a little ahead of the curve and better planning. But in regards to the equity and justice issues, I put a link in the chat to something that we're doing in the United States. And I'm pleased to say that in the last few months with the new administration in the United States, there's been a lot of focus on environmental justice and equity. And there is a equity and justice COVID task team that is actually trying to, you know, ask these questions. And one of the things that our National Integrated Heat Health Information System has been doing is urban heat island mapping for several summers. There is an inherent environmental justice issue with some of that, which hasn't really been brought out until now. And of course, it's quite obvious. So we're doing that to help map the urban heat island so we can understand it scientifically, but also it's a pretty rigorous citizen engagement piece. So the data are actually usable, and it does begin to help it helps the conversation happen in a different way at a more local level as well. So it isn't directly solving the environmental justice issues. We're hoping that some of, legislation passes and things like that. But at a community level, it is actually changing the conversation, just getting people out. They're out doing their own sampling. It's under a methodology that every city's using, and it's, common method so we can compare results. And it's not perfect, but it's consistent and it's a good baseline. So we're happy to be able to be talking about using that a little bit more to solve some of the environmental justice things moving forward. So, but it has helped change the conversation. I have seen that happen myself. It hasn't amounted to policy changes yet that I'm aware of at a national, but maybe at a local level, we're just not sure. Thank you for the chance to answer that, though. And it's such a great opportunity to be having that discussion now. So
it is, isn't it? And having the discussion now. And thank you for putting the link into the chat box there, because people can look more at that. Geneviève, what would you most want to do as a public health leader in addressing these inequities that have only gotten worse through COVID? So what could we most do in the recovery plan?
Yeah, this is really important. So of course, the most vulnerable were also the most affected by COVID in a way. So we need to learn from that, and global warming and environmental risks, or maybe the source of the next big crisis in terms of impact on health. So for us at the agency, or the Public Health Institute, we have at least 2 or 3 main priorities. The first one is to strengthen our epidemiological and surveillance studies to illustrate the impacts of heat on all health dimensions, and also include the potential to describe the specific indicators by specific categories of vulnerability. So this is quite important, not very much developed in France so far. So we need really to move that. The second thing aspect is also to initiate and strengthen also collaborations with local stakeholders. In a way, we need to think globally, but to act locally, and so also to develop innovative tools so that they have comprehensive, integrated information about health impacts and the importance among more vulnerable population. And of course, the third aspect is to develop advocacy strategy to make the case for adaptation to heat, and also adaptation that is adequate for different populations, including those that are more vulnerable. So I would like just to add one thing in terms of vulnerability. Cities were, and that's absolutely clear that they need to be involved, in stakeholders at the level of cities, but also the professional environments. Because that's also an environment where heat and global warming can have impact, and where also there can be more vulnerable people to heat based on profession.
Geneviève, as ever, thank you. Ramiz, do you have a connection?
Yeah, I do. Thanks. So when we discuss about the inequalities, from our experience, I would say, as a collective, as an institution, to me, the foremost action we believe is required is to set a clear vision by the respective local or national government to make an equitable and inclusive society. We believe that without a political, or I experience that without a political will, we cannot attain this equal distribution of resources. So why I'm saying vision, because government has to set the goal if they're focused on economic development or making an inclusive or holistic development for the overall prosperity of the citizen. If they have this vision, then it is much easier to recover the equal distribution of the resources. Apart from that, I think local level planning and actions is very important for the equitable distribution of the resources. For example, both to deal with COVID-19 and climate change, and climate change impact and heat wave, because national and provincial plans and policy often doesn't relevant to the local context or doesn't get accepted by the local stakeholders, or even poses negative impacts, which we call as a maladaptation. So suppose we plan plan our actions considering the local context, involving the local community partners or community-based organization. In that case, we can directly reach out to the vulnerable group and make the process, I think, more equitable. Thirdly, I believe the social safeguard measure or social safety net, especially for the vulnerable people, is required. For instance, as COVID or climate-induced disaster or heatwave events relief, I'm saying, if we distribute an equal amount of cash or food items or other essential commodities to all the impacted people, we are basically making rich richer. We have to categorize the population group based on the socio-economic condition and plan to provide the degree of relief accordingly. I'm here giving an example in terms of relief materials, but I want to mean basically special social safeguarding measures for the most vulnerable population in the society, and that is how we can bring them up, and the recovery we can make it more equitable. Lastly, I think as a preparatory action, we need to adopt more anticipatory mechanism. For example, focus-based action or focus-based financing or early warning, early action work to reduce the heat risk or the impacts in the first place instead of later going for the mitigation. So we need both. We have to think about the mitigation approach, but at the same time, we have to also think about the preparedness or preparatory action, so that they exposed to the they're less exposed to the risk. For example, we can develop a heat trigger for a particular city or a particular region or a particular province. We can undertake some simulation, and we can develop an early warning protocol in collaboration with the stakeholders, the humanitarian group, the meteorological institution, the health institution. And I think if we can make this preparatory action on place and effective, I think we can reduce the impact to a greater extent, that we do not need to go for a equitable recovery. At the first place only, we can reduce the impact. Yeah.
Ramiz, thank you. Incredibly good point. Very powerful. I'm going to give 30 seconds each to Owen, Shubhayu, and Werner, and then some just final remarks. Owen, did you want to add anything? You have 30 seconds.
Thanks, Duncan. I was just going to comment about how the vulnerability to heat is broader than just the intensity or the magnitude of the event itself, and how there are links to housing and social, economic, and status, but also the synergies that exist between COVID-19 vulnerability and heat vulnerability. So it's important in our recovery, which needs to be just and resilient, that we bring up the need for greater resilience that would work across multitude of extreme weather events, including heat.
Thank you, Owen. Beautifully said. Shubhayu?
Just to sort of, reiterate what Owen said, the social vulnerabilities that we worry about when we talk about extreme weather events, related to climate change, align, very closely, unfortunately, with all the, the risk factors that are extremely important, in our response to control, the pandemic. At a much higher level, as we think about strengthening, health system resilience, it's going to be, we are going to be, remiss if we do not add the climate perspective as we think about how we make our health systems more resilient. So I really hope that at the highest levels, these two actions are coordinated and synced, to get us maximum, protection as we move forward.
Thank you, Shubhayu. Thank you. Werner?
Yes, I would like to add that, in the Netherlands, we have also local adaptation plans, and I think it's very important to also look which organizations are already there, are already working locally, and how can you participate with them. For example, we have in the Netherlands organizations for house rental for the social care system, so people can rent houses there. And it would be good that the houses they rent are not only warm in the winter, but also cool in the summer. People are 80–90% of their time indoors. So if we always look at the outdoor temperature, it's the indoor temperature which is, I think, also very needed for to look at.
So Werner, thank you. And I want to, in the last few moments, the timing of this seminar is not an accident. It follows initiative from the WHO, and of course we've got COP26 later this year. As Geneviève says, the most vulnerable are the most affected. And Céline spoke of it being inconceivable to think of a post-COVID recovery plan that did not reflect climate change in all of its different dimensions. And that the risks that we speak about all the time about the most vulnerable are heightened again around heat, and seeing the consistency there is both encouraging in the sense that we know what we can do to improve on this, encouraging, discouraging, because that's what we have to do, and that's what we will be seeking to promote through IANPHI, through our national institutes, and through our governments. Think globally, act locally. Ramiz made that point, as did Geneviève and others. I want to end by saying the biggest possible thank you to our speakers and panelists. Thank you so much for putting in this time and being so rich and giving in your contributions. To say a big thank you to the US CDC for the interpretation, which has made it possible for us to listen and understand each other, and the Secretariat of IANPHI for all the organisation that's gone in today. We will make sure there's a note that follows today, and of course what matters the most is what follows in the implementation of this great conversation. So can you take away everyone's thanks for your contributions, and until the next time, thank you everyone.